So Dr. Yu and Ashley, if you could come join us up here. So as they're getting settled in, I just want to mention in preparation for these sessions that we have a number of pre-recorded educational videos that you can review on our website, and they're located on the bqi.org website on the members only section under registry education. So the rest of this today, before we get to our poster presentation, we are going to, these sessions are for you guys. And so it's going to be very laid back. I really want everybody to feel comfortable walking up to the mics and asking us questions, or our online remote participants to open up their questions and ask questions. We have our physician experts as well as our data manager experts sitting as our panels to answer any questions. So we encourage people, don't be shy. Please come up, and we'll do our best to alternate between live questions and online questions. So Dr. Yu is from Pittsburgh, and he's going to be joining us. Ashley Fletcher is from Centara as a data manager. We have Dr. Lemon, Dr. Jorgensen, and Dr. Maribi as our panelists. So with that, we're going to launch. We're going to ask you all to answer these questions using your ARS keypads. We have provided handouts at the table that outline each of the panelists in our each of the sessions, as well as inclusion-exclusion criteria. So with that, we'll launch our first question. So our drill procedures, which are distal revascularization and interval ligation procedures, an exclusion from the hemodialysis registry? Yes, they are exclusions and not collected. No, these are collected as a primary procedure, or drill procedures are collected as part of the long-term follow-up data collection. Very good. Dr. Yu, would you explain to us a little bit about what a drill procedure is?
Yeah, so the drill procedure is performed when a patient has ischemic steal syndrome, and this is fairly uncommon. It has definitely seen, but there are patients when a dialysis access, a hemodialysis access is constructed, a vascular access like this, the artery is being asked to do now two things. It's being asked to perfuse the hand distally, typically. It's also asked to provide flow through this AV access conduit. And sometimes the artery is just unable to provide that flow. And in those cases, usually something suffers. Sometimes it's the graft or the fistula, and in that case, the fistula just fails. But in other cases, it's the hand or the distal extremity that suffers and is unable to be perfused adequately. That's called ischemic steal syndrome, or access-related hand ischemia, frequently because it's in the upper extremity. And there are several options to treat this. One of the options, and kind of the classic option, is this procedure here, the distal revascularization and interval ligation procedure. And it's a very long name, but it essentially involves two components. One is the distal revascularization. This is essentially a bypass from a relatively normal, hopefully, part of the brachial artery where it's typically performed. And it's a bypass from that part of the artery to the artery distal to the anastomosis with the AV access. And then you actually do a second part, which is you ligate or divide many times the normal artery in between. And it's those two components that are considered part of the procedure. This is not actually a procedure that creates the access. This is typically done after an access is created and is beginning to cause some issues. So that's part of the reason we don't capture this as part of the index procedure, but it's something that is done many times afterwards, or sometimes afterwards if the patient has the right clinical situation. So it is collected. It's collected as part of the long-term follow-up data, but it is not something that is, again, an index procedure, which means also that if a patient gets referred to your facility as from an outside, somebody else has created the access, and you haven't recorded that initial procedure, you're not going to record the long-term follow-up for that procedure either. So that's a small little wrinkle there in the data collection. So this happens, and I will have to tell you that in my 9 years now as an attending, I've done one drill procedure. There are different ways also of treating this. There are other revision options, but it's definitely something that is done and is fairly well established in the literature. I don't know if anybody else has any other comments.
I just want to make sure that everybody knows, you probably don't know, but these are real-life questions that have come through Pathways. And so I tried to pick some of the more common themes for our ARS questions. And if anything comes to mind, keep it. We have a couple more here, and then we'll open the mics up for all of you. We're ready to go. So our next question, a patient has a history of an AV fistula. LTFU showed a severe stenosis of the proximal right cephalic vein just distal to the anastomosis, which was greater than 80%. Where is the intervention? Outflow, inflow, or central? Dr. Yu?
I guess that's kind of an interesting question. I think one of the, maybe I want to get kind of the other panelists' thoughts about this too here. When you start talking about an AV access, I think there's typical anatomic terms we use, proximal, distal. At least for me, when I think of proximal and distal, I always think about this anatomically, that proximal is just closer to the heart and distal is further away from the heart. But when it comes to like this AV access, you sometimes kind of get a reversal of that. So the anastomosis is, many times like further down the arm, and then distal to the anastomosis. It's not totally clear to me actually sometimes what that means. I guess when I think of just distal to in this context, it seems that the distal to the anastomosis is in the outflow, just beyond that connection. And when I read this, it seems like that the blockage is right at the anastomosis. So I guess I would consider this kind of an inflow intervention. I don't know how other people feel about this. Because when I think of an outflow intervention, I usually think of something that's like at the cephalic arch, which is in some sense kind of closer to the heart in that way. I don't know how other people, Dr. Lemon, Dr. Murby.
Well, I think based on the fact that it indicates it's an proximal cephalic vein, that it's actually beyond the arteriovenous anastomosis or distal to that particular anastomosis. So the anastomosis is a center point based on this question. So I guess I would consider it an outflow intervention because it's in the outflow tract of the vein itself, as opposed to a central intervention, which would be mostly caval or an ominate vessel treatment. In terms of inflow intervention, to me, I view that as a inadequately treated arterial system. It's inflow to the reference fistula.
So in the artery itself, is that what you would say?
Correct. It's in reference to the actual fistula, not necessarily a proximal distal location anatomically within the body. So I would view this as the actual anastomosis is the center of the case and the procedure here, and inflow would necessarily be on the arterial side.
So would you make a distinction then between, say, a cephalic arch stenosis and what this question seems to be asking, which is a stenosis kind of in the vein at the anastomosis? Would there be a distinction in your mind, or at least based on this data collection here?
I don't, because I consider cephalic arch stenosis still a peripheral vessel in terms of that. It's not a central vein.
For sure, but you consider those both outflow intervention? Yes. Dr. Murray, Dr.
Yeah, I agree. I would consider it an outflow intervention. I think of the fistula itself, and I'll be honest, some of the terminology is, proximal, distal, I think we get confused. So I freely admit I'm making an assumption about the original construction of the fistula, but a cephalic vein is a superficial peripheral vein, so I would not qualify that as a central intervention. It represents where the blood leaves the fistula, so, to not be overly simplistic, I think this is an outflow intervention. And I agree, the inflow is what provides the power to the fistula, which, at least in my mind, is on the arterial end.
Yeah, I think we all agree this is definitely not a central intervention. This is definitely not the cava. This is not the innominate vein. This is not even the axillary vein. But I guess where we maybe have some, difference in opinion here is then kind of what constitutes inflow versus outflow. And also to be clear, I think part of the challenge to this particular question is we don't have a picture. Like we don't know exactly what this is. What they're referring to, but
I would just say, I think we're making this a little bit too complicated. I would say an artery is the inflow and the vein is the outflow.
the one issue there is that, an intervention on the artery itself is also quite rare. I mean, I've done like thousands probably at this point, and I've rarely actually put a catheter directly into the artery and angioplasty of the artery, like specifically. Usually most of the interventions are at the arteriovenous anastomosis, and what's being angioplasted is typically the vein. So I guess based on what I'm hearing here, these would all be considered outflow interventions,
Yeah, I think
regardless of whether or not it's at the cephalic arch or whether or not it's at the anastomosis.
Scott, you want to weigh in?
To a problem with the terminology and where we should learn something from our interventional nephrologist. So the next iteration of this, we need to change the terminology. For a fistula, there's the juxtaanastomotic segment, which is what we're talking about here, the cannulation zone, and the outflow. And that's, if we're going to have good granular data to make meaningful conclusions from, we need to make sure everybody's talking about the same thing. So again, I think we need to revise how we describe the segments of an access.
Yeah, I think that's a good point. Also because, sometimes the treatments for, say, a cephalic arch stenosis will be very different from what you treat at the anastomosis. With the cephalic arch stenosis, sometimes people are actually putting in covered stent grafts. In fact, there was just a paper published in JBIR talking about the different ways that could be placed. So far, hopefully nobody's putting a bunch of stents at the arteriovenous anastomosis, but, as technology changes, we'll see. Those are different beasts, and I think to Scott's point, the next iteration of this should make definitely a distinction between the juxta-anastomotic portion and others.
As an aside, I think that this conversation, however we want to look at it, this is incredibly important because this gets to what, every time we update a registry, we try to bring, new and updated understanding of how we talk about how we look at things, and this is what gives us this is what generates the power in the data. So these conversations are incredibly important.
I was just going to say, given that point that he just made, I'm pretty sure, I cannot remember now because I'm in my head about it, but I'm pretty sure there's actually on the long-term follow-up form a segment, there's all these boxes that populate when you say that there's been an angioplasty or something done. And I don't think these are just, I know this is only 3 of the choices, but I think a more appropriate one that is available is fistula balloon angioplasty. So there's an inflow, there's an outflow, and there's fistula. So if it's like in that cannulation zone, I would call it fistula balloon angioplasty. If it's further than that, I would call it outflow. But generally, I would consider anything beyond, what you guys were saying, anything beyond the anastomosis to me, if these are my choices, I'm going to go outflow. And if it's arterial, I would say inflow.
And you're completely correct on the form. On the actual form, it's inflow artery, outflow vein on the long-term follow-up. You're exactly right.
Ashley, do you have any? I'm sorry.
Yeah, I definitely agree. And there are others, the nephrologists, as was mentioned before, also have some of this terminology as well, but definitely being able to standardize on that will make our work also more interoperable with others that are interested in this field.
Ashley, do you have any comments?
I'm afraid my answer is going to be a little bit less nuanced because I agree. I was going to go with the outflow intervention based on it being located in the vein. And if it was the artery, I would say inflow.
We have some work to do. Yeah, go.
Carolyn, we don't subscribe to the hemodialysis access, but is there a pictograph with definition of terms on the pathways?
Is there what?
Is there a picture?
I don't believe there's pictures in the dialysis. There might be one, but it's not
I
associated
think that
with
would
this.
probably help avoid a lot of confusion if we create a picture with definitions that we are considering it inflow, outflow. And
Great idea.
so-
So our third question is, during AV graft creation, there is some bleeding from inside the subcutaneous tunnel. The graft is found to be deeper than intended, both proximally and distally. Therefore, the graft was elevated. Would concomitant superficialization be abstracted?
So I guess when you place a graft, it's very important to make sure that the graft is tunneled appropriately. This is something I think that's kind of drilled into every trainee. It's definitely every trainee that works with me. I'm kind of fastidious about the tunneling of this thing. However, I have seen sometimes in which the graft gets tunneled through the biceps, which is not great. But I've never actually personally done that. So I guess in this case, the graft was tunneled in a way that was suboptimal. But the good news is that the graft was, this was identified in the surgery, and it was presumably taken out and then retunneled. I'm not sure if that's what that means, unless they, I guess, they just tunneled it deeper in the fat than they expected, and so they decided to take some fat out. I consider this just part of the surgery. I guess I wouldn't necessarily consider this concomitant superficialization. What would other people think?
Are there any examples that you can give us where there would be a concomitant superficialization?
Not of a graft. I mean, the thing about the graft is you have complete control over the anatomy where you tunnel this. I mean, this is not, you're not hostage to the vein being, 2 centimeters deep because of subcutaneous tissue. This is, you have the tunneler in your hand, and you should be able to put it where you want to. I guess the other option is, this is something I could imagine somebody tunneling it a little bit deeper than expected, and then not being happy with it, and then fixing it in some fashion. But I guess the solution again would just be to disconnect it and retunnel it, not to superficialize it. I don't know, how do other people
I
feel?
certainly agree with you. I mean, calling it concomitant means like an additional procedure. I mean, the procedure is you make a superficial tunnel with an AV graft. That is how you intend it. And it somehow seems as if it's, a takeoff on a AV fistula with a bacillic vein fistula, where you might do a concomitant superficialization at the time of the operation. So, I'm not sure I understand the question either.
This is a question that just recently came through, so again, I see opportunity for us to work together and better definitions, better pictures.
Well, let me ask, is there an option to describe it as a superficial
Yes,
for a graft?
yes,
Is this done on the same day?
yes.
Okay,
Same hospital visit, same OR visit.
okay, that makes a difference, because the question sounds like it was done at a different time which we're all familiar with in terms of superficializing a vein. But it's done on the same day. It's an inaccurately placed graft. And revision should be done regardless the fact that it's additional work. It's a graft placement, period. It's just that it wasn't done right the first time.
And the question suggests that there was some bleeding from inside the subcutaneous tunnel, again suggesting that it was maybe tunneled through the muscle. Yeah, I mean, the good news is they caught this before they closed the patient, so I think that should be kind of, given some credit there. And, sometimes these things happen. But, I would definitely not consider this concomitant superficialization. To me, I think the correct answer here is B.
Superficialization shouldn't even be an option that you can check if you put it in the graft.
That's what I'm saying, that maybe there are opportunities for us to clean up and make some revisions to tighten things up a little bit.
And to be clear, this is kind of unlikely. I mean, I would have been really surprised. This would not have crossed my mind as being something that people would do. But I guess now that we know, we can, adjust the form. Okay.
From the abstractor perspective, I would have abstracted that as a concomitant superficialization because it was unintended. It happened as a result of something that happened during the procedure that wasn't planned. So because it was an extra intervention that isn't common for sure, then that would be a prompt to me to capture that in some way during the abstraction.
And our last question that we have is, during this same procedure, as we mentioned earlier, the patient identified a bleeding point distal to the superficial vein branch and controlled it with clips. Should this be abstracted as a post-op complication? Woohoo! That's an easy one.
This is, so in all the op notes at the very end, I just say, I obtained hemostasis. You find a superficial vein branch, you clip it, as long as it's not closed. As long as the patient's not closed and off the table, whatever you do, just as part of the surgery, it should just be part of the surgery. Now, if the patient left the operating room, is in the PACU, and now has a huge hematoma, well, yeah, that's different. That's a post-op complication. But even if it's a moderate-sized hematoma, that should still probably be captured in some way. But this is pretty clear to me that this is just part of the surgery. And, the surgeon, this may not have been the best case, but it seems like the surgeon, did the right thing, got the graft a little more superficial and fixed whatever was bleeding.
Lucky, thanks. This is one where I would actually argue for consistency between the registries. So in the PVI registry, for example, if you have a flow-limiting dissection in the SFA during angioplasty, that's recorded as a complication. At least that's been my impression in a number of emails that I've gotten back. So that really shouldn't be, right? So if you have something like this where you're controlling bleeding intraoperatively because there's a branch, that's not a complication, you're just fixing what's happening. I think it's the same thing in a lot of other registries, though, where you have something that's happening intraoperatively that's a natural consequence of a procedure. I think it requires a little bit of a look at each of the individual registries. That's kind of want to make a plug for that one. We've been talking about that in the open aneurysm registry revision already. Thanks.
He's my champion. He's helping with Donna Fleming, and we're working on our AAA registry. And not to make excuses, but it's true. We're working to try to harmonize all these things between all the different registries. But it's a work in progress, and I think it's going to keep me working until the day I retire. So keep me there. But yeah. But anyway, yeah.
Was that the end of the questions?
Yeah.
Can we go back to question 1?
Oops.
So, again, I don't participate in hemodialysis. Is for ischemic steel, are we only capturing drill? Are we capturing other forms of revasc?
Yes, absolutely, yes.
And we have a couple more minutes before we're going to take a break. So would someone care to help us understand how someone decides between doing a fistula versus a graft creation? I mean, I know back in the day, it was always fistula first, but things have changed. So what goes into the decision-making behind that?
Yeah, so this is something that's been kind of battered around for, frankly, I think as long as fistula first came out. Certainly in the past, 40, 60 years ago, I guess, when the fistula was first created, Brescia, Sabino, and Appel, they just found literally a suitable vein right next to a suitable artery, typically in the forearm. And that vein hopefully just got bigger, and then they would just stick it with needles. As time passed, it was very clear that there are certain veins that were better than other veins. And so you would use the cephalic vein, typically in the forearm, cephalic vein in the upper arm. But there are limitations to that if the patient doesn't have a good cephalic vein or it's not the right diameter. And the initial people who got fistulas were typically young trauma patients. This is how they kind of came to be as something that was useful. But then as time passed, we, of course, were giving fistulas to different kinds of patients with perhaps less great anatomy. And in those cases, if you don't have good anatomy, you can create anatomy. We're surgeons. We can use a different kind of conduit. And when these prosthetic conduits came on the scene in the 70s, these were then used and seen as different options. The problem with a graft, of course, is that it's not autogenous. These things tend to fail a little more quickly. And so there was this movement then to get patients away from the grafts towards the fistulas. From the surgical perspective, it was just easier to put in a graft. And so I think in the late 90s or late 80s, maybe others can speak to this, there was definitely a preponderance of grafts that were being used. But again, we thought this was maybe not as advantageous to the patient. And so after the Fistula First initiative came on board, we decided to go as autogenous as possible, fistulas whenever we could. Of course, now we discovered that the fistulas weren't working as well because patients were getting, failed surgeries because they were behind the 8 ball to start with. The anatomy wasn't great. And so over the last few years, and this was seen in the 2019 KDOKI guidelines, there's been now movement back towards understanding that sometimes a graft is a good solution for a patient. It's not necessarily for everybody. I think on balance, if the patient has good anatomy for a fistula, they should probably get it. But there are some reasonable situations in which a graft is probably a better solution. Sometimes the patient doesn't have good anatomy. Many times the patient doesn't have good anatomy. Sometimes the patient actually has a preference towards having a graft as opposed to a fistula. Fistulas tend to take a little longer to mature. And some patients just don't like that. I'll give you an example. My father-in-law is a 82-year-old male, and unfortunately he is on dialysis. His veins were terrible. And I was having a discussion with one of my partners about which access to give him, and I thought pretty clearly he should get a graft because it would get him, get his catheter out a lot faster. Now, he ended up getting a fistula. It turns out that this did take some time to get it to mature. It's been 6-7 months, but this actually finally did work. It did require secondary intervention. But in that case, I think there's reasonable equipoise between having a graft placed or a fistula placed. And that's kind of one of the dynamics that's occurring. And I think one of our quality metrics and one of our reports is actually why was a graft placed? It's not necessarily that it's a problem that a graft was placed, but I think it is important to at least document why. And one of the options could be simply the patient requests it, and as long as there's some understanding for that, I think that's a legitimate reason, and it's definitely something I think that's right for future research.
Yeah, it's an excellent discussion, Ted, and I would augment that in indicating that this should be a decision of catheter last, and that the individuals who are in front of you may have a possibility for both. They have a vein which could be used, they have a possibility of graft, but if their CKD level is less than 20 milliliters per minute in terms of their GFR, you know that that vein that you create a fistula for is going to take probably at least 3, if not more, months for it to be successful. And 70% of patients currently continue to start initiation of dialysis via catheter, and we should not have that. So in a situation where a patient who has maybe a questionable vein and you think you can do it, but is in imminent need of dialysis, that patient should have an AV graft to get started for their access. You can use that either immediately or within 2 weeks, depending what your preferences are. And to keep that patient away from having catheter-dependent sepsis and infection and recurrent admissions. So keep in mind that, as he said, there may be a reason to decide to justify one versus the other, but the most important thing is to don't start a patient on dialysis with a catheter.
Well, thank you, everybody.